The left ventricle, which is the easier ventricle to talk about, I think we'll all agree. Thank goodness I didn't have to talk about the right ventricle, because I really don't understand the right ventricle. And there were a few sort of issues we were going to discuss during this talk this morning. It's a bit on left ventricular function and semi-quantitative grading, a bit about ejection fraction. People get very hung up in ejection fraction. So the oncologists will often say, please give us a number. I say, well, you know, it's not really a number, it's more in a continuum, but we give them numbers anyway to keep them happy. We'll talk a little bit about global systolic function. We'll touch on regional wall motion abnormality. That's really a whole talk in itself. And the interest of trying to make this more interactive and sort of maybe less cumbersome, we will touch on that, but maybe not go into huge detail. And I'm going to mention cavity size, because I think cavity size is terribly important. We're all going to have learning objectives nowadays, and after this lecture I'd hope you'll be able to assess LV function in the acutely ill patient. I think we'll all understand the limitations of echo even in the best hands, and then maybe think in the clinical setting of the cause of LV function in the critically ill patient. I think as clinicians we come to it with an advantage that we can sort of try and pull all the bits together, so not just taking the echo in isolation. Of course, the sine qua non of the critically ill patient is organ failure. That's why we get to see them in the settings we do. And of course, there may be multiple organs at stake. Being a cardiologist, of course, I really care about the heart. And the biggest question really we need to know is, where does the heart sit in the sequence of events that has rendered the patient becoming ill? And I would maintain that the echocardiogram is among the most useful tests when it's correctly used to get us that far. That's all fairly obvious, I think. Sometimes, however, you don't really need 45 tests. This was a clip provided to me by my sister of just one picture that says it all. So we'll just start with a very dramatic example of how a heart shouldn't look. And this is not a uterus with a baby. This is a heart, surprisingly a bad heart. And here we have a very large thrombus sitting within the left ventricle with heterogeneity within the thrombus. So really, this is just a bad heart. This was a massive left ventricular thrombus in a patient who had suffered major myocardial infarction, was elderly and frail, and didn't actually present with chest pain ever, just presented shocked. And this is what we want to, hopefully I'll catch you a little bit earlier than this, but this is the use of echo. Sometimes the echo just makes the diagnosis, and further testing is really not necessary for a lot of cases. I tend to like Ohm's law. I apply Ohm's law every day in my life, V over I by R. And I think it's important to kind of translate that into the clinical setting, whether it's the pulmonary or the peripheral circulation. We can translate Ohm's law of V over I by R to blood pressure being the voltage or the mean perfusion pressure, cardiac output corresponding with the amperage or the current, and resistance or capacitance depending on what you're looking at. And of course, really, the left ventricular ejection fraction is one of the components that determines the cardiac output among many others. And of course, the echo will give us an idea of the LV function. And that's sort of where the technology fits into assessing a patient. So when it comes to assessing LV function, size really does matter, because it's unusual, particularly in chronic states, in chronic states where there's decompensation, to have normal left ventricular dimensions with significant LV dysfunction. Of course, it can happen, and perhaps happens a little bit more frequently in the acutely ill patient. But size really, so left ventricular dimensions are critically important, and we keep coming back to those. It's also important to say that the left ventricular ejection fraction is semi-quantitative. To give it an ejection fraction of 36.2897% is absolute hogwash. And as I said, the most interesting group of clinicians that we interact with frequently would be the oncologists, who really get totally hung up, because it's the threshold for therapy and it's very important, but you try and explain to them, hang on a sec, it's not actually 59.87%, really it's not, but it takes a little, they kind of get the hang of it eventually. One thing that I think we all know looking after critically ill patients, but sometimes people out there don't realise that the ejection fraction is dependent on loading conditions. It's not just a number fixed. So depending on what your systolic blood pressure is, your echo will look quite different. If somebody comes in with a hypertensive crisis and a blood pressure of 200 over 100, their LV function will look quite different from a blood pressure of 120 over 80. There's a marked difference between the two. The other thing, particularly in the intensive care setting, is that if somebody is on an infusion, for example, dobutamine or adrenaline, the ejection fraction you calculate will be artificially higher. And again, that's okay if you're the clinician involved in the patient, but it confuses people who just drop in and out on the patient. And I think one thing that we're probably poor on is recording whether or not the patient is on inotropes when the study is done. That's critically important and is often overlooked. Similarly with afterload reduction, so we tend to use nitrates and nitroproside from time to time. If you use good afterload reduction, you can actually augment the ejection fraction by reducing the afterload. And then finally, as we discussed this morning, and I think as was discussed in one of your previous talks, the ejection fraction can be measured in a variety of ways. So put simply, the ejection fraction is a simple mathematical derivation, and from the basic physiological textbooks that we all learned in medical school, essentially we're assuming that a 5'10", 70 kilogram male has an end diastolic volume of approximately 120 milliliters. And we're assuming that in the standard situation that you eject 70 cc's, that your stroke volume is 70 cc's. In other words, that your end systolic volume is 50. So that's where we get our nice number of 70 over 120, and mathematically derived, the ejection fraction is 58%. Now, of course, I just told you that there's no such thing as an ejection fraction, but at least that's where it starts from. It's the starting point. And everything we do in echo is to try and make an estimate, make some sort of measurement without using the extraordinary lengths you actually have to go to measure actual ejection fraction in the physiological model. So for that reason, there are multiple methods. For sure, there's marked inter-observer variability, and that's where I think the repetition, the looking at the normals, the looking, that there has to be that. And also, what should be done in a good core lab is there should be maybe 10% of echoes are read twice. So I think there's this idea that because there will be a little bit of interplay between different readers. I think as clinicians, some of us like to be sensitive. We like to kind of pick up disease really early, and some of us like to be specific. We kind of want to wait until there's a problem. We kind of have that hardwired into us. As I said, it's not in absolute numbers, and we'll talk about the composite approach. And I think it's really important that certainly when I quote ejection fractions, I always quote it plus minus 5%, because you really cannot be more accurate than that in echo land. So these are the issues, these are the calculations. I know that some of these, there's a previous lecture that Roisin sent on, which I looked through, and some of this has been covered, so I'm not going to reinvent the wheel a bit, but we just pop through this in a clinical setting. The M mode, it's been around for a long time. It's the one that I think cardiac physiologists are often much better at than the clinicians, because I think we as clinicians are often trained to multitask, polytask, but there's a huge amount of value in the M mode. And a good parasternal long axis view will give you a very good estimate of left ventricular dimensions, which, as I said earlier, is the starting point in assessing LV function. What we try and do is get the M mode cursor, ideally through the septum and posterior LV, but it's all about getting it right on axis. And in the acutely ill patient, that's often the one view you can't get. And it's often the view you can, so you kind of take what you can get. But if you're lucky enough to get it, it really does facilitate a good estimate of global ejection fraction. So the strengths is that it's very reproducible. So, you know, until the days of availability of images at most of our workstations, which we now have, if you had a printout, which used to be on old-fashioned thermographic paper, you could actually look at the image. It was a real image to look at. You could tell a lot by it. And when the patient is lying supine, the parasternal long axis is often the best view to get, actually. And I think most echo labs do it as standard practice and to a very high standard. The problem is you have to get the axis right. If you're off axis, you'll underestimate the dimensions, and it makes huge geometric assumptions. You're assuming that the width of the ventricle correlates with the length of the ventricle, and that works fine in the normal heart. But in the sick heart, in the cardiomyopathy, in the particularly atrial myocardial infarction, it won't take into account, for example, an apical infarct. So you might get a totally normal ejection fraction based on this method, but the patient might have had an apical heart attack, have lost their apex totally, but it's not measured in this. Okay? And there are other things that cause problems. Older people often have septal thickening. So we talk about sigmoid interventricular septum being a normal finding in the elderly. And a lot of elderly patients, this won't be as accurate because you'll be starting off with altered alveolar thickness of the septum. And of course, as I said, it doesn't allow for regional almost abnormalities. So this is a recent case. These are all cases that I looked at recently, just to kind of make it as real as I could. And this is the best I could do at measuring the left ventricular ejection fraction. So the packages are standard nowadays. What you're looking here, you're going to measure the left ventricular internal diameter. So that's this here in diastole. And you're going to time that, of course, to the electrical signal that is the QRS. and then you're going to take it in systole. Now, it's meant to be somewhere towards the end of the T-wave, but honestly, the best thing to do really is eyeball it and make sure you get in the thickest piece. When it's a beautiful, clear tracing like this, it becomes relatively easy. However, I will challenge you. Where did I put the cursor in the right spot here? Would you put it here? Okay. So again, it's down to experience. It's not the thing you want to do at 3 o'clock in the morning for the first time in your life. It's the thing you want to do in loads of normals, so that if you're comfortable as a methodology. And I said, you know, our cardiac physiologists are absolutely masters or mistresses of this. I'm not sure that the clinician that throws a probe on at 10 o'clock at night is going to be doing this. But it is a very useful and again, often a very reproducible number. But clearly you're going to miss anything that's happening out of the apex. It's improper to make a comment on the apex in the parasternal long axis view. However, using that, you can come up with a fractional shortening method, percentage fractional shortening. In this case, the left ventricular ejection fraction, I calculated incorrectly, by the way, at 70%, because I don't think I put the cursor in the right spot. I actually think that probably should be there. Okay? But it's relevant and it's a useful way of checking. This is the same idea, but slightly different. It's just where there is a calculation made on the, instead of the fractional shortening, instead of how much the muscle is thickening, it's how much the cavity changes in size. And in fact, these are pretty much automatically done by the computer. Again, the problem is, you know, edge definition. Where do you put your cursor? Where do you measure from? And again, you have to take these as just indicators. You couldn't hang your hat on it totally. Similarly, if you look here, this the computer came up with a geometric assumption of 125 cc's. That's based on the normal shaped ventricle. It falls apart if you have a dilated ventricle, if you have an apical infarct. So these assumptions, the geometric and mathematical assumptions generated to give an ejection fraction of 70%, don't hold up in the abnormal state, or in the older patient as well. Simpsons, actually, which I don't know why that slide jumped there, but whoever it come the wrong way. So Simpsons is easy to remember because most of us watched the TV program for many years and still do. But it's become, again, core echo labs would tend to use Simpsons as a standard approach. And what you do is you're taking the left ventricle, which is the area is the easier ventricle, and you're assuming that it's made up of a series of discs lying on top of each other. And when you do that, you can make some geographical mathematical assumptions that allow you to calculate volumes. So Simpsons is a method for calculating volumes in systole and diastole, and thereafter allowing a mathematical derivation that will produce an ejection fraction. So what you do is you attach your ECG, obviously, you get the best apical 4-chamber you can, and ideally you'll use an apical 4-chamber and an apical 2-chamber view, and that gives a better 3D estimation. In practice, a lot of the time you just do it in the apical 4-chamber. The difficulty is, of course, particularly in the supine patient that can't adjust their posture, that can't lean over on the left-hand side, perhaps if they're ventilated and they're very sick, you really don't want to be moving them around. You may not be able to get nice, clear, spanking views. So this is all based on good edge definition again. And quite simply, and I know you've had slides on this before, the idea is to trace out the endocardium and systole and trace out the endocardium and diastole, and using that you will get an ejection fraction. Again, it has to be taken into consideration. In these views here, you can miss a posterior myocardial infarction in its entirety. So using this methodology, you'll get a normal left ventricular ejection fraction if the patient has an acute posterior infarct, because you don't get that wall in this view. And that's a significant weakness. So as I said, it's really not perfect. It's sometimes hard to get a good apical 4-chamber and an apical 2-chamber view. And certainly that's the view, for me personally, I find the hardest to get actually. I find a good apical 4-chamber can be my hardest one to get. The other thing about it is that the near field is very difficult in an ultrasound. So the near field is obviously where the ultrasound probe is emitted from. And this is the area that is often, that the edge definition is at its poorest. And that's terribly important because if somebody has had an apical infarct, that's the very area of the heart where the regional wall motion abnormality is, and that's the area of the heart that's hardest to see, because the focal point of the ultrasound beam is generally a lot further down into the field, somewhere down around here. You can get very technical and you can readjust the focal point of the ultrasound beam, but you're getting into very technical changes then when you have a load of other things going on with the sick patient. But it can be done, and sometimes it should be done. And of course, the other thing about it is that because the ultrasound beam is effectively parallel to the lateral wall and the septal wall in this view, it's less accurate for picking up edge definition again as well, because the movement is this way and the ultrasound beam is 90 degrees to it, it's perpendicular to it. So again, it sounds perfect in theory, but in practice these can be very difficult measurements to make. The good old eyeball is next, so let's just take a picture and look. And I confess, this is what I usually do. So you'll take a picture, which isn't playing on this slide, so we'll move on to another one, but you'll take an eyeball and you'll say, look, I think the heart looks good, I think the heart looks bad. And of course, it's often the best, really, because if you can get 3 or 4 views, you can tell an awful lot about the heart, but it does require experience, because if you take a 28-year-old marathon look, and I confess, this is what I usually do. So you'll take a picture, which isn't playing on this slide, so we'll move on to another one, but you'll take an eyeball and you'll say, look, I think the heart looks good, I think the heart looks bad. And of course, it's often the best, really, because if you can get 3 or 4 views, you can tell an awful lot about the heart, but it does require experience, because if you take a 28-year-old marathon runner, and if you haven't seen 28-year-old marathon runners' echoes before, you will underestimate their ejection fraction if you eyeball it, because they tend to be a little bit bradycardic. They have a very efficient fractional shortening, and their heart looks almost lazy. And some of the measurements that I just talked about will actually look as though their LV function is below normal. But we know their LV function isn't below normal. So unless you're looking at a lot of echoes and looking at the normals, you have to be very, very careful about eyeballing an echo. I would be cautious of being dogmatic. Be humble. Say, I think it's somewhere in around. Don't be too dogmatic. And always take multiple views. Never ever take an EF eyeballing without taking some measurement of diastolic dimensions, and actually a whole other talk diastolic function as well. But if the dimensions look normal, or if the dimensions, for example, are mildly dilated, again, in a very healthy marathon runner, be a little bit careful before you call the ventricle down. You might be barking up the wrong tree. I'll come on to that later on with lots of examples of eyeballing the LV function. I'm not sure how much you touched on tissue Doppler. Tissue Doppler is no longer considered a new technique. It's a relatively new technique. And while we're very familiar with color flow mapping, whereby we apply the Doppler principle to assess when the red blood cells are moving below, towards the probe or away from the probe using the bar principle, so blue away, red towards, we can use the same technology to ascertain the direction of movement of the tissue and the speed of movement of the tissue, hence tissue Doppler. And what we're looking at in tissue Doppler, there's a huge emphasis on tissue Doppler on diastolic function, and that's a whole other story and a very interesting part of echocardiography. But we can use tissue Doppler for systolic function as well. And just to briefly mention that, this is a slide from Circulation from Ho. It's a very nice, very simple review of tissue Doppler going back to 2006. And what you see here is the paper emphasizes the diastolic parameters. And I'm going to show you the systolic parameters. What we do is we have the tissue Doppler area of interest placed on either the lateral or the medial annulus. And we're looking at the excursion of the mitral annulus in systole. And there are normative values produced for systolic excursion in systole. It's useful numbers. On average, healthy young people will have velocities of maybe 12 centimeters per second. Once you start getting below 10, you begin to question dysfunction. And if it's, say, 4, 5, or 6, you can pretty reliably say that systolic function is reduced. It isn't useful in every case, but I will show you an example later where it did prove useful. The other thing that I like about tissue Doppler is it tells me an awful lot about diastolic dysfunction, which I'm not going to talk about today. But it's almost unheard of to have isolated systolic dysfunction. You really can't have good going systolic dysfunction without an element of diastolic dysfunction. And when you're trying to differentiate transmitral inflow patterns, tissue Doppler is extremely useful in making sense of transmitral inflow patterns, which again is a whole other story. I don't know if you want that covered, but it's something we could look at another day. But tissue Doppler, good snapshot in time, and I'll show you a little bit about that. This is a tissue Doppler in a case that we had recently in the intensive care unit, where we demonstrated we couldn't really get good 4-chamber images, but we were confident that the ventricular function was significantly reduced because the peak systolic shortening was way down. Here it's about 4 centimeters per second. So even though this was an obese patient, this was a ventilated patient, we could get very little. Even though all that went down, we could get an estimate of overall left ventricular systolic function with a simple technique, which is just one button on the machine. Okay? So it is something you should just, but please don't do this for the first time on a sick patient. Do it lots of normal patients to get the hang of it. The VTI is talked a lot about in the intensive care literature, and it's talked less about in the cardiac literature. I'm not quite sure why that is. Certainly I don't use this as a routine tool. And putting the talk together, I had to go and scramble a little bit to get my slides together for this particular. So the idea is that you're looking at stroke volume rather than left ventricular ejection fraction. So you're using stroke volume, then you backwards work to get LVEF. The idea is that you're going to put your area of interest in the left ventricular outflow tract, and you're going to assume that using the integral or the velocity time integral of the Doppler signal of the left ventricular outflow tract, that in some way that will give you an indication of stroke volume. And if you know the stroke volume, you know the heart rate, usually to calculate, you can get the cardiac output, which is really, that's gold dust really. The problem is that it makes a lot of assumptions. The way you're meant to do it is get a nice left ventricular outflow tract tracing, measure the left ventricular outflow tract diameter, and from that diameter you're going to get a radius through which the blood is ejected. So if you know the radius and you have the velocity time integral, you can actually calculate the stroke volume with a very simple equation. Now, actually calculating the VTI is based on integration, remember from your mathematics, which thank goodness nowadays is done by computer. To do it manually is actually tricky. So very simple mathematical assumptions. And this is really what it looks like. I know Roisin did this in her talk, but it's effectively you put the probe ideally in a 5-chamber view, left ventricular outflow, and it all looks very simple, doesn't it? It really isn't though, because the assumptions you make break down in a whole variety of the sick patient. It's fine in the normal healthy patient, but there's a lot of assumptions you make that don't apply in the sick patient. So for me, the challenges in using VTI is the obvious one is that if you mismeasure the radius, the error is squared, because it's R squared, area of a circle. Again, like the 4-chamber view, the 5-chamber view can be very difficult to get in the ventilated sick patient. And if you do any off-axis measurement for the peak velocity in particular, you're going to cause an error which is related to the cosine of the axis, just to basic simple trigonometry. So, in my own experience, I find that the VTI systematically underestimates the stroke volume and hence the cardiac output. And that's before you take into account that, of course, the stroke volume is going to vary with filling. And, of course, filling will vary on loading conditions, and loading conditions will vary on ventilation, positive pressure, all the issues that go on in the sick patient. So a lot of these were validated in healthy people in a core physiology lab, and unfortunately a lot of these assumptions fall down in the sick patient, which is the patient we're interested by and large in. And similarly, a lot of these are only ever done when you're asking a question. So I would advise people not to use this technique unless you do it in a lot of normals. And people might have their own feelings on it and make people use this in the room all the time, but I tend to be cautious in interpreting it. So to kind of come back to ejection fraction again, it's very confusing. It's very confusing because I don't actually know what an ejection fraction is, because I know what it is mathematically. I don't know what it is in my head as a picture. And I think it's really important to use combinations. Never take it in isolation. If it doesn't fit with the clinical picture, look, go back, question, query. Like it might be a case that the ejection fraction is measured at 50%, but the patient appears to be in cardiogenic shock. Well, yeah, but they're on a bucket of adrenaline, and they're on dobutamine. If you dial it down, their EF is actually 25%, and what you're looking at is the stress echo. Never hang your hat on a single number, and I would caution you, if the VTI looks like the cardiac output is 6 litres per minute, please don't just take that as a single number. And it's really important you document hemodynamic support when making assessments. Now, there's many times when being as cautious as you can, taking everything into account, you still can't make up your mind. And there are tricks which, I'm not sure how many people use LV contrast. We use a moderate amount of it. There are downsides to LV contrast. I've seen anaphylaxis with it. There are contraindications to it. But it can be very helpful to opacify the left ventricle. It's particularly useful in stress echo as it happens. Transesophageal echo is marvellous because, particularly for the sick patient, you just pass a probe and you can take pictures. The problem with TOE is that unless you know your surface echo really, really well, TOE is subject to a lot of artifact and I think echo, and particularly TOE, it's like playing the harmonica. It's very easy to do badly. To do it well is tricky. And particularly for making measurements of LV sizes, if you're slightly off axis in a TOE probe, you can really upset the system. And if you're not absolutely obsessive about taking standard views in TOE, you can see a whole pile of things that aren't really there. There are lots of other things about TOE we could talk about, but because of the technical differences in frequency of a transesophageal probe compared to a surface probe, and because now our machines are so clever, they'll automatically change things like the pulse repetition frequency, the PRF. So if you have a patient and you see a lot of mitral regurgitation on a transesophageal echo, that may be entirely artifact because the PRF was changed automatically by the machine because it's a higher frequency probe. In other words, there's a lot of stuff that goes on in the machine that unless you're really familiar with the basic fundamentals of ultrasound, which most of us aren't, quite frankly I'm not, that you can actually get the wrong information because you make the wrong set of assumptions. So TOE, for those of you who use intraoperative TOE in the cardiac theatre, you're masters at it. But TOE, just for your first time on a Friday night at 10 o'clock, may not be the best time to start using the modality. And I'd emphasise actually interpreting the ECG, which you're probably much better at, taking the chest x-ray and gosh, even the clinical exam, working that into your diagnostic algorithm can sometimes be as good as anything else will do. Okay. A brief list then of causes of LV systolic dysfunction, and there's a huge list, and I think it's more useful to think in the boxes, to think where are the areas you're looking at. Obviously myocardial ischemia and infarction is right up there, and in a 65-year-old male that's taken and shocked, that's like number 1, 2, 3, and 4, especially if he was well until it just happened. Cardiomyopathy, either primary or secondary, so rather arbitrarily we say secondary cardiomyopathies would include things like valvular cardiomyopathy, pericardial cardiomyopathy, stress-induced cardiomyopathy, and primary cardiomyopathies are meant to be these genetic cardiomyopathies, for which we're beginning to understand the genetics most recently. That's somewhat artificial because you could argue that if somebody has a genetic cardiomyopathy, but they drink 20 pints a day, they're more likely to have, inverted commas, alcoholic cardiomyopathy than their brother or sister who doesn't drink at all and appears to have a normal heart. So I think this trying to dogmatically say what's a primary cardiomyopathy and what's a genetic susceptibility with an environmental trigger has become much more complicated. Sepsis is a very common cause of significant and transient, hopefully, left ventricular dysfunction in the acutely ill patient and is often missed because the patient comes in under, for example, the surgeons with a hot gallbladder, gets septic as be damned, is managed in a surgical manner, then somebody says, well, they're not doing well, and the ECG doesn't look too different, but you put the echo probe on them, and lo and behold, the LV function is down because they've got sepsis running through, and that's where the intensivists get involved and save the day, I hope. There's an epidemic of Takotsubu's or stress-induced cardiomyopathy. I think mainly because we look for it a lot more often. I think probably it's not more common. I think probably just make the diagnosis a lot more often. And we're probably taking sicker people through theatre. So I think it was last year, there was a case here of a lung transplant patient that got Takotsubu's perioperatively. Did well, actually, pulled through. So we see all sorts of things. And of course, following CPR, if you have a cardiac arrest for an electrolyte disturbance or an overdose, the heart looks sick after resuscitation. It's very hard to, particularly now in the days of cooling, not from an echo perspective, it throws the ECG into wild sort of shapes, and it's actually harder to interpret after cooling, which clearly saves lives. That sort of ends the dogmatic, didactic, dry portion of the talk. What I want to do now is do a bit of knowing through showing, and just basically try and discuss a few cases. I've purposely chosen recent cases so that I'd actually remember what is going on with them. And I've chosen some pretty pictures, and I've chosen some ugly pictures, because that's the world we work in. So, does anyone have any questions at this point? I mean, is there anything that, or do you want to just know and show and ask questions at the end? Okay, afraid to ask. Okay, so I'm just going to fire ahead then and just run through these, and please feel free to interrupt or throw stones or anything. This is a nice picture, unless you're the patient, and this is an echocardiogram of a young boy, 20, who presented with what is called norovirus. So he had a history of cardiomyopathy in his youth, so there was a history, and he was on low maintenance medication and actually was doing very well. But he presented with acute vomiting and nausea, very unwell, pale as a sheet, and a highly functioning individual, and just fell off. Came into a hospital, was treated with fluids, didn't have a particularly low blood pressure, lowish blood pressure, not truly shocked. And they did liver function tests, and he had transaminitis in the 2000s. So he had a shocked liver. And this is his echo. So what you can see here is, without, let's pause it actually, let's put our money where our mouth is. So we happen to have just nicely caught it in diastole. So again, it's very important when you're looking at an echo that you don't just say, oh, that looks big to me. Because of course, it might look big or it might look small depending on the settings of the echo machine. Okay? So this is the focal point here. This is the arrow showing the focal point. So the ultrasound beam is focused here, which is entirely appropriate. And you can see the way the depth is set. So the depth setting on the echo machine will determine what the measurements are. So if you didn't see 5, 6, 7, 8, 9, 10, if we hadn't that on the slide, you couldn't say that the ventricle was dilated or not, because you've nothing to measure it from. So you can measure it here. You can see it's somewhere 5, so 1, 2, 3, 4, 5, 6, yeah, we'll say 7. 7 centimeters, that's big. So this young boy has a big ventricle. He's dilated, first thing. So now, okay, good start there, right? And even if you haven't looked at a million echoes, this doesn't look like a happy heart, does it? So it's hypocontractile. This wall doesn't seem to be thickening. One thing that's particularly difficult in echoes is discerning what's thickening and what's moving. So if you look very carefully, this isn't really thickening all that much. Now it's moving, but it's moving because it's being pulled. It's not moving because it's thickening of its own muscle activity. So that's the first view. So what's the ejection fraction? You can't answer the question because you don't have enough information. This is one view. You can eyeball it and say, it's not good. Now, that could be very useful in a quick setting. So whether the ejection fraction here is 22.3897% or 34, it doesn't matter. This is not a good heart. And I'd argue to you, you've already answered a lot of your questions before you go any further. But let's take another view. So that is the parasternal long axis view. This is the, let's get my cursor right here for you guys. This is the parasternal short axis view. So shockingly bad, right? So really this lazy heart. Few comments on this. I didn't take this echo, one of my colleagues did and did a superb job. But there's a lot of brightness here. So the gains are actually very high in this. Now that doesn't matter because just a little myth is out there that if you have a bright pericardium, you have pericarditis, okay? This man doesn't have pericarditis. This is just that the gains were very high to increase the endocardial definition, which is highly appropriate. Mm-hmm. Just beware of the bright pericardium, okay? Anyway, that's a side point. So again, in this view, very importantly, what don't I have here? I don't have the valve in view. If you have the valve in view, you can artificially underestimate the left ventricular function because where the valves sit in the annulus fibrosus. So this is just above the level of the papillary muscle. So it's nice to get a view, but it's actually not the view that you take left ventricular dimensions in. But I show it because you've got global hypokinesis here. Okay, so just nothing looks right. So then we take the aforementioned M mode, and the M mode is extremely useful. So this is the M mode here with the area of interest put across the atrium. What I didn't mention, what is extremely important is, if the atrium is big, that implies certain things. This atrium is big. If the atrium is big, what that is telling you is that either, for example, the patient's in long-standing atrial fibrillation, you have an atrial remodeling. That's not going on here. But if the atrium is big, that's telling you that the atrium, which is by definition a low-pressure chamber, has been subjected to increased hemodynamic stress. If the left atrium is big, we're saying either, for example, blood is leaking from the left ventricle back to the left atrium over a period of time, or blood can't get from the left atrium to the left ventricle. So the left atrium is a really, really good indicator of what's going on in the left ventricle. Really important. And it's a very easy thing to measure. This left atrium is big, and this left ventricle is big. But hang on, we got 5.7 centimeters. Didn't I think it was 7? Okay. So the point is, no single technique is going to give you absolutely consistent. So the point is, I don't really mind whether it's 6.1 or 6.2. It actually came out at 6.9 on this, right? But it's only a freak that it's kind of anywhere within a few millimeters. And I'll be honest about it, you'll keep measuring until you get the same answers. Human nature is to round it out. But this is a big heart. The ejection fraction based on fractional shortening here is 34%. I don't believe it's 34%. The end diastolic volume based on the geometric assumptions we were talking about earlier is 246 cc's. Now remember we said the normal left ventricular end diastolic volume in a 5'10", 70 kilogram male, of which this guy is, should be 120. So I actually think that's probably not a bad estimate in this guy. I guess his ventricle is twice the normal size. Now because his ventricle is twice the normal size, if you look at his left ventricular end systolic volume, it comes out at 162. So if you use the subtraction of LVESD and LVEDD, you're going to get a preserved stroke volume, which is actually physiologically what happens. It's one of the reasons that people compensate. is that because the volume of the heart increases, there's relative preservation of the stroke volume, even though the left ventricular ejection fraction falls off. So that's what happened this guy. So, and this is the same thing again, looking more at volumes. Again, we got a 34% again. This is Simpsons, same idea. In this particular instance, Simpsons was pretty easy to do with lovely edge definition, so you get pretty good measurements. Again, all about 34%. But really, I suppose the bottom line for this is that does it really matter if you measure that at 33% or 24% or 29%? You know this guy's ventricle isn't good. And I just think that's a particularly good shot for a few reasons. Firstly, that kind of vigor you see in contractility, its movement of the heart is not thickening. Okay? So you could be fooled into thinking that his ventricle is a little bit better than it is. Secondly, I didn't tell you if he's on an inotrope or not. You didn't ask, did you? Thirdly, the right ventricle is extremely important, and I just wrestle with the right ventricle the whole time. But you get the sense here that even the right ventricle ain't so good. The left atrium is huge, okay? And there's something else on the next slide, I think, that will just over it. So this here is a very useful indicator. So what's going on here? So there's mitral regurgitation, okay? Now, I briefly mentioned earlier pulse repetition frequency, PRF. What's really important is if you look up here, it's about 61. Now that's very relevant because if the PRF is 61, that's what we usually used to looking at. And the pulse repetition frequency is generally set automatically by the machine based on the frequency of the transducer probe and to a certain extent the distance of the probe to the area of interest. And the area of interest here is correctly adjusted to being about 12 centimeters. Okay? If that was a TOE, the PRF would automatically adjust down to about 45. And what's at least moderate mitral regurgitation would look like torrential mitral regurgitation. Okay? I'm only just using that as an example to say that the settings in the machine have a profound effect on what you see and what you interpret. And unless you look at lots and lots of normals, you can really get yourself into trouble. However, this guy has at least moderate, and again, estimation of mitral regurgitation is at all times semi-quantitative, is at least moderate mitral regurgitation. And in this case, his valve is actually structurally sound. This is functional mitral regurgitation. Because he's got a dilated left ventricle, the chordae are actually being tethered, so there's failure of coaptation of the leaflets. And what you'll often see is, even though that's said to supposedly cause central mitral regurgitation, because of asymmetry and because of the way the mitral valve is structured, often the posterior leaflet will be tethered a little bit higher than the anterior leaflet, so you get a slightly posterior jet of mitral regurgitation. So in this young gentleman's case, we had a very low cardiac output, even lower than you might have estimated by the ejection fraction, partially contributed to a significant degree of mitral regurgitation. And this guy's management was very straightforward. We gave him an inotrope to increase his cardiac output to get him over his shocked liver. What is surprising is that his liver ultrasound showed very little congestion. Okay? So one of the reasons we see abnormal liver function tests in the ill patient, particularly with the low cardiac output, is back pressure through the liver. But in this young gentleman's case, it is a true case of cardiogenic shock presenting with acute shock liver and all that goes with it. No. So his actual, again, the assumptions we make on chronically ill patients, his IVC was very minimally dilated. Okay, so in measuring his left atrial pressure, we missed the boat on him because we actually swanned him, and that's a whole other talk. Because to be honest, the Swan-Ganz catheter, the right heart cath, is profoundly important in the ill patient. I would argue in a whole other day. And while you can play around with echo and get estimates, which are very valid in the well patient, in the ill patient, unless you're really meticulous, you can either underestimate or overestimate intracardiac pressures. So we underestimated this guy's intracardiac pressures by about, I think, 20 millimeters of mercury. So the difference between 35 and 55 on his right ventricular pressure. Okay? The reason we underestimated is his TR jet was very minimal. He has a very competent tricuspid valve. Okay? If we had a good TR jet to work with, we might get it right. But we're going to swan him anyway because I wanted to know the cardiac output, and I cannot estimate cardiac output without a swan. And I know they're non-invasive measurements. I'm getting some bizarre looks in the audience, but this guy was swanned, and his mixed venous oxygen saturation is 42%. Okay? So he's doing okay, but there's a lot of work to do. So that is just one case where I think, was relatively straightforward because we had lovely pictures, we had single system disease, there weren't many flies in the ointment, and it became relatively simple to manage. What might be more difficult is perhaps a more commonly encountered scenario, particularly in any cardiothoracic centre, where you have the fella that's 2 days, you got him out of the ITU, he's 78, he's a long list of comorbidities, he got through the operation, it was grand, you know, he's 78, you want to get him back home as soon as you can, get him, there's that window of opportunity to get them going, but of course he crumps. So he gets out of bed and he just falls to the ground, and a cardiac arrest is called, and there's the usual confusion, and by the time everything is gathered, he's kind of saying, what's going on, what's going on? So was it really a cardiac arrest, what was the rhythm, the stickers had fallen off, his telemetry, you know. So of course an echo was done, and this is his echo. So does anyone want to make a comment on this echocardiogram? Does anyone want to be very brave and say anything about the echo? Okay, well you're saying nothing because we've only one view, that's a fair point. But like, it doesn't look like the worst part of it. But do you want to ask me, so like, is this done after an arrest situation, inverted commas? So is he on an inotrope? We don't know, it's not stated. He's not actually. Is there anything odd about how the heart is moving?
Disconnected.
Yeah, now that's a good point. So is it dyskinetic or dyssynergic?
Synergic.
Yeah, it's a tricky one. So
looks very small.
okay, and that's a very useful point to make. The RV looks small, but this is not a real 4-chamber view, you see. So if you haven't got the view, right, you're not going to really be able to comment on the right ventricle.
Right septum looks like a word.
Okay, so he's got this. So he's got a lot of things. He's got a 78-year-old heart for a start, and he's had his aortic valve replaced. And most of the time, the 78-year-old is aortic stenosis. So he's going to have hypertrophic changes, isn't he? He's going to have hypertrophy. And as I think I mentioned earlier, you'll often see a sigmoid interventricular septum in the elderly. So there was a whole disease called hypertrophic cardiomyopathy of the elderly back in the literature, which thankfully we don't talk about anymore. But so I won't say it's normal, but it's commonly seen to have quite a hypertrophied septum in older folks. So it looks like HCM, but it's not, it's just a sigmoid septum. So he's got that curveball. He also, as you correctly said, has an interventricular conduction delay, but you kind of get a hint on his ECG. See his ECG down there? It shows a wide QRS. So he's got distal septal dyssynergy, okay? And you can't tell just from the ECG, because we don't know what lead it is, whether that's left bundle branch block or right bundle branch block, okay? Or non-specific interventricular conduction delay. Or, if he's post-surgery, he still might have his pacing wires in, so it could be paced rhythm. All you can say is that he's got a dyssynergy. That's all you can really say. And I would caution you to be able to say with definitiveness that his ventricle is good, bad, or indifferent. So I just throw that up to say, that's just the one shot. Just be careful on the one shot. And you correctly didn't fall for it and make a comment on his ejection fraction. Let's take another view. In fact, let's take 2 views. So this is the parasternal long axis view. And this is the parasternal short axis view. And I'm just purposely showing you these because this is the real world. This is the real patient with the real... these are the views we get. They're not the beautiful ones I just showed you. So now you'd be a little more confident, wouldn't you?
What's your
Tissue. Isn't it? Yeah, nice job, yeah. But at 78, you can have to do anything else. 5 to prosthetic valve at 78, better profile, lower gradients, avoid the anticoagulants and so on. No, and in fact, that's the critical piece of information. Like, the radiologists are very good and robust at not reporting the study without being given clinical information. Sometimes the sonographers and the cardiologists and the intensivists may be a little bit soft and give an opinion without knowing all the facts, so we should be more careful. So, so this is a good looking aortic valve here, nicely seated. And again, if you didn't know the clinical details, you might know that it's aortic valve replaced. You do get a sense of it here because it is a little bit echo-dense in the sewing room. So parasternal long axis view, a very nubbly septum. Does anybody know which area, which coronary artery supplies the area I'm just showing you here? I'll open this down first. So the basal septum. Basal interventricular septum. Unfortunately not, especially right coronary artery. It's a mistake to make. So every other bit of the septum. So in that particular view, you've got to be a little careful. Just so, again, and you get a nice systolic excursion. So for a 78-year-old man, if we can velocities up at about 9 centimeters per second, I'm confident his pump is not the problem. At least the systolic portion is pump. And in fact, his diastology is pretty good too. Because if you only get into the diastology of it, you can see that you've got actually, effectively, the tissue Doppler equivalent of VA reversal, which indicates that his diastology isn't too bad either. So then, just to compare those two cases, if you look at patient A and patient B, when you put them beside each other, you do see a big difference, don't you? Both patients, if you look, there is this kind of almost frenetic vigor. If you really, it's moving, isn't it? But it ain't thickening. This has frenetic vigor, but it thickens as well. So train your eye to look for thickening, not just movement. We all look for movement, but thickening is where it's at. Because thickening refers to shortening, and shortening translates to ejection fraction, cardiac output, and what matters. This is another one that Roisin gave me. Thank you, Roisin. Well, the patient I was looking at, but Roisin did the picturing. And this is a 56-year-old gentleman with a history of diabetes who presented with an acute late presentation myocardial infarction. And he managed to dodge the inotropes, but he didn't get as far as the intensive care unit, but he came in and he was sick. He had rising creatinine, he had impaired hepatic function, he had congestive cardiac failure with bilateral crepitations, he had an elevated JVP, he had a gallop rhythm, and he had an ECG that showed persistent but probably fixed anteroseptal ST segment elevation. So, as a doctor, you'll know all that. So it then makes interpreting the echo very, very easy. And that's the point I'll make. As a clinician, we are really looking. We can put all the pieces together quite well. But looking at his echo, this is the Roisin's parasternal long-axis view. So a sonographer with 45 years of experience. This is the picture. But now, if this is what Roisin got, I'd hate to tell you what I got. Okay, I wouldn't give any pictures. I wouldn't have found this hard. But so, if you merely took one shot, right, in the intensive care setting, and okay, because of what I told you, and even though we're not meant to look at the apex, you do get a sense that the apex isn't happy, even though you're not meant to comment on the apex, right? But if you look at this fractional shortening here, you look at this view here, this is vigorous contractility, which of course, that's exactly what happens. If you've got a regional wall function abnormality, the other portions will all bail in there to give a hand. Okay? So in fact, what you get is hypercontractility in the non-infarcted area. Why do you get that? Well, sometimes it's because the patient is put in an inotrope that this man isn't. But of course, it's the inotrope the body produces. The profound sympathetic catecholinergic outpouring that goes on in the acute patient, so that the patient's on his own adrenaline infusion, which is why for a day or two they seem good, and then suddenly they crash and need the inotropes. So what you do next, of course, you get another view, and in the other view, you do get a sense that this is not a happy heart. So I hope it's okay. Yeah. So you don't get that this is not a happy heart. So this is quite a shocking finding. So the differential diagnosis of a late presentation myocardial infarction is, so does anyone say what this is? I hear thrombus, I hear fluid. So the differential, firstly, let's look at the wall. This is a massive disconnected segment, but this isn't the wall, right? As Francis says, this is actually something, is it the wall or is it thrombus? We think it's thrombus, we hope it's thrombus. Because within thrombus, what is it? It's rupture, yeah. So you have a patient sitting calmly waiting for his breakfast or his lunch or his dinner, and he's sitting there quietly, and you know that at any moment he could expire. So it causes tachycardia in the team, shall we say. But clearly, if you're like, what? So his ejection fraction, look, if you did fractional shortening across here, if you did Simpsons across, you'd actually get not a bad ventricle. But he's a terrible heart. Who cares what do I really care whether you tell me the EF here is 30%? Now, it depends on how you present it. If you want to get into a surgeon and say, oh, EF is 35, go for it. But really, what the hell does the ejection fraction tell you here? Bad heart, something's here. So what might you do? So like the New England Journal case report, what next would you do? What test would you do? A diagnostic test was performed. Would you wheel him down to the MRI scanner? Well, you petition, you get a letter from the Pope to get to the MRI scanner for a cardiac MRI. So, yeah, good idea. So, use contrast. Now, this is a contrast chart. You happier now? So, it probably doesn't go through. Okay? But there is this regional wall motion abnormality, which is quite dramatic, which shows dyskinesis. I hate to tell you, I did that from the ECG, by the way, the gallop rhythm and the heart failure. So, just confirming what you saw in the ECG, but massive dyskinesia, very low flow, You don't need to measure the cardiac output to know that the cardiac output is going to be low here. But luckily, what I don't think is free wall rupture. Okay, so the contrast, I can't mention it again, the contrast saved the day there. Okay, there are some concerns about using contrast in acutely ill patient, but we found it very useful in this case to clarify the diagnosis. So just one more case, and we'll call it a day or morning. So just for the audience, any comments on that? Very good. So in the shock, you have a heart that's floating. So again, I know we're talking about ejection fraction, but the big picture here is her ventricle entirely normal? Probably not. Probably not. She's got pacing, you got that dyssynergy, which is harder to see. So that same dyssynergy that you saw earlier isn't as evident if you've got pericardial effusion. All right? So she's got a big pericardial effusion. She's got right atrial collapse, which doesn't always give you hemodynamic compromise, but she's actually got good going right ventricular collapse. Okay? So this was a shocked lady, treatment very straightforward, pericardiocentesis, and Ted was on call that weekend, and all was well. So, just to summarise, I think I've just about filled up my time. I think that the good thing about coming to ECHO as a clinician is that we come to it with clinical knowledge and we come to it with a global perspective. And it is bizarre to look at an echo and just say, oh, the ejection fraction is 30%. It's just nonsense. And I think we really have, as doctors, to take the clinical situation into account. A very good quote I always think is, don't say anything until you've seen everything. So to just throw an echo probe in someone's chest and say, oh, ventricle's down, thanks, is a bad thing. And if your friendly cardiology registrar comes up and does that, slap them across the side of the face, okay? Be patient. 5 minutes extra, taking very careful images and trying to do your best for the patient can save days in ICU. If you get the diagnosis right initially, if you back the right horse initially, but it might even save lives if you start off with the right time. I think in my own experience, it's when you start off backing the wrong horse that you go down a road, and the further down a road you go with the clinical diagnosis, the more then you use other tests to justify the wrong diagnosis. I don't know if you ever find that, but you kind of go down a road and that whole area of diagnostics. And I would say that, not that I lose any time, but the greatest addition to the intensive care unit is an echo machine that resides in the intensive care unit, so that we all speak the same language, so that we work collaboratively between cardiology and intensive care medicine. You don't actually have to marry them, but you could if you do. But the idea is that you basically, that the echo machine is an integral part of the intensive care unit, so I don't have to go down and get the thing up. We all work together, and that our fellows would be involved in taking images of the unexciting patient. You know nothing tonight, let's have a look at the echo. And that's what's become the norm in a lot of units I work in, and units I work in, and I think it's a great thing. So practice, 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 know the normal, and play to your strengths. There's a couple of websites which are actually good that go through some of this. Some of them are actually ICU websites I found, and I'll put that up in the link as well if you want to do a little bit more reading. And that's the end of the talk. Thank you very much.